Well, hello, and thank you for tuning in today for this presentation on the science behind COVID-19. My name is Roger Kapoor, and I'm the Senior Vice President and Chief Medical Officer here at the Beloit Health System. A few quick items to highlight. For the medical professionals joining this session, this presentation is accredited for continuing educational credit, so please feel free to reach out to the individuals listed on this slide if you need assistance in obtaining a credit certificate. For everyone in attendance, you each have the opportunity to ask questions throughout the presentation by clicking the Q&A button below. Any questions you submit will come directly to me, and then I'll get to them at the conclusion of the presentation. We really have some strong attendance right now and actually are getting close to our maximum capacity afforded on this platform, which is 3,000 attendees at once. So in case you know somebody who wasn't able to attend, please know that we will be recording this session for people to view it or share it later. And I think before we get started, I want to take a moment to say thank you to our healthcare team members that continue to go above and beyond each and every day, and literally risking their own safety in order to protect others. And that is really the fabric that comprises healthcare teams. It's the calling that brings each and every one of us into this field. But while I've known many of you for your dedication and passion and commitment, I've got to say that in these unprecedented times, a challenge in the face of the unknown and real danger, you're nothing short of heroes. Thank you from the bottom of my heart. It's truly humbling and an honor to work amongst you. Please continue to stay positive and know that we are all in this together and that we will get through this because of each other. Okay, well, let's get started, and I'll just highlight our agenda. Today we want to review the epidemiology, diagnostics, clinical manifestations, and treatment options of COVID-19. And we're seeing a continued extraordinary expansion of the COVID-19 pandemic, with 2 million reported cases worldwide and President Trump declaring a major disaster in all 50 states for the first time in our history. And I want to take you back here to the early timeline, how it all began. As you remember, COVID-19 is a new coronavirus related to the Sars virus, SARS-CoV-2. It began in Wuhan, China, which is a city of approximately 11 million people. The first officially reported case to the CDC was back in December 27th of 2019, when a physician noted 3 SARS-like pneumonia cases in one family in the hospital. And then these cases started to pour in with a cluster of 41 patients who had very similar mysterious pneumonia-like syndrome. And by December 31st, a public health alert was issued. On January 1st of 2020, the seafood wholesale market in Wuhan, which all the cases at the time had been reportedly connected with, was closed. And then by January 7th, scientists had isolated the new virus. On January 11th, the PCR diagnostic test on the new virus was completed, and China unfortunately had to report its first death due to COVID-19 on the same day. On the 21st of January, the US reported its first case, which was a 35-year-old gentleman in Washington State. And on the 23rd of January, Wuhan shut down for public health measures and was placed under quarantine. And then on January 30th, the World Health Organization, for the 6th time in its history, declared a public health emergency of international concern and a global public health emergency. Over just this span of time that I've reviewed, we've already had 100,000 reported cases and 3,800 deaths. And since then, the virus has continued to spread. And here's a brief map provided by the New York Times illustrating the reach of COVID-19. And as you can see, the epicenter spread from China and Asia to Europe and then the United States. And although not gone in Asia, it has subdued and I think A large part of that is due to their prior experience with SARS back in 2002 and 3, in which their society and economy was severely devastated. And when COVID-19 came around, they acted pretty fast. They did a massive ramp up of testing. They already had a culture of wearing masks in public when they were sick, and they implemented robust contact tracing. In other words, they were looking for people who were in contact with known positive COVID-19 cases. And of course, they had quarantine systems. And as you know, the virus can infect cells in the mouth, upper respiratory tract, lungs, and gut. One of its characteristics is that people who are infected have a really high viral load and can transmit that virus to others before and during initial symptom onset. And as we know, it can be fatal. There is no known cure and no vaccine at the present time. And here's a very interesting article that came out in the New England Journal of Medicine talking about the stability of the SARS-CoV-2 virus, the virus that causes COVID-19 disease. And what it's talking about is its stability on different mediums. And what you can see is on the y-axis, we have concentration of virus, and on the x-axis, we have time delineated in hours. And you can see it can live on things like copper for a short period of time, cardboard, it can stay there for about a day, stainless steel and plastic up to 3 days. But the thing that really catches my attention is the first graph over there on the left. Here, it was found that the virus was found in the air, lasting for up to 3 hours. And this has been a big point of discussion regarding PPE, or personal protective equipment. And the takeaway point is that there is probably the ability of this virus to be transported by aerosol, and it's likely on many things that we're touching. So we need to be really cautious, and maybe it's more aerosolized than we actually realize. Here's a graph simply showing you the continued daily increase in the total number of confirmed COVID-19 cases over time. Here's another graph showing you the daily new confirmed cases, and you can see in February in China, represented by the blue line, there was a significant reduction, but then we started to see a number of confirmed cases rapidly increasing, first in Italy, the red line, then Spain, the green line, and then the United States, the yellow line. Here is that same information projected onto the world map, again, just simply giving us perspective to the gravity of COVID-19's reach and impact. A similar graph now showing you confirmed COVID-19 deaths by day. We've had over 100,000 deaths worldwide, and countries with the highest number of deaths are again Italy, here represented in red, Spain in green, and then the United States in yellow. So when we look at epidemics and pandemics, we discuss a term called the case fatality rate. And that's the number of deaths per cases reported. In other words, the numerator is the number of deaths, and then that's over a denominator, which is the total number of cases reported. In the context of an active, ongoing, emerging epidemic, these numbers are evolving and dynamic. Let's look at the case fatality rate. And right now, it's ranged between 0.2 and 7.7. And again, that's largely dependent on the context, the population that's affected, and the stage. What I mean by that is, for example, if an epidemic started in an extended care facility or a nursing home with generally older populations there, we'd expect the case fatality rate to be much higher earlier, because we know that COVID-19 impacts the elderly more. But then as we continue to have spread of the disease and more younger populations get infected, we would expect a decrease in the case fatality rate, since the denominator of infected individuals would increase, but not necessarily those that were dying from it. Because we're not testing everyone, the true case fatality rate is not going to be known for some time, but one thing we can say with confidence is that when you look at the graph on the upper left, the case fatality rate here in China and in Italy, it's clear that higher ages are associated with higher fatality rates. So, for example, the mortality rate is pretty low up until you get to about the age of 50, where you see the mortality rate is about 1%. In the 60s, it goes to 3.5%, and in the 70s and 80s, it's up to 15%. Other contributing factors to death include comorbidities such as diabetes, hypertension, and cardiopulmonary disease, and we're going to discuss that a little bit later. Interesting, we're really seeing a very little impact in terms of death in our younger age groups. And in the graph on the bottom left-hand corner of the screen, the takeaway point there is that COVID-19 has a higher case fatality rate than the seasonal flu. Again, the exact numbers are in flux, and as more data comes in, this will become much more clear. In the US, we've had over 500,000 reported COVID-19 cases, and unfortunately over 20,000 deaths. The virus definitely infiltrated our country using land, air, and sea. And we've seen nursing homes and cruise ships become sub-epidemics. And the IHME, or the Institute for Health Metrics and Evaluation, released a model that predicted that the US would likely reach approximately 80,000 deaths before this was all over. Now, unfortunately, our coastal states got infected first, and those included places like California, Washington State, New York, Boston, Louisiana, likely due to Mardi Gras. And now we're starting to see a spread towards the central United States, impacting places like Michigan, Illinois, Indiana, and Wisconsin. Here's a graph published by the CDC, and it's demonstrating a concept called flattening the curve. It shows the natural history of a pandemic in the solid purple color where no interventions are put in. And what we'd like to gain by our interventions is to decrease the slope of the rise of new infections and, of course, to flatten the peak. And that's represented in the second curve in hash marks. So you might ask yourself, how do we get from the solid purple curve to the hashed curve? And the answer is we follow the public health playbook, which really is the isolation of positive cases, the quarantining system, enhanced infection control at all facilities, including hospitals, public education on hand hygiene, and what's called respiratory hygiene, how to properly cough. In this particular case, that's not actually enough. We need to do population measures, such as social distancing, community-wide cancellations, widespread community quarantines, otherwise known as shelter-in-places, and even border closures. So we have to ask ourselves, as we implement these measures, are things like social distancing actually working? Are people following these recommendations? Well, there are a couple interesting ways we can track its progress. And here's a comparison describing the percent of people who are traveling in 4 major cities, Washington, San Francisco, Boston, and Chicago, this year as compared to last year. And you can see that as time has gone on, our travel has significantly reduced, nearly 90% in these 4 cities. Here's another really interesting satellite image here of Italy, demonstrating the levels of nitrogen dioxide, which, as many of you know, is emitted from vehicle exhaust and the burning of coal, oil, natural gas, things that can contribute to our pollution levels, and it correlates generally to our industrial output. And you can see there's a significant reduction of pollution since social distancing efforts went into place. Certainly another interesting metric to follow is the observation of our evolving shopping habits and behaviors. And here are several articles kind of highlighting how we have changed our behaviors with time, going after everything from seeking toilet paper and hand sanitizers to hair color and gym equipment, pet food, and puzzles. Here's another great article from the Beloit Daily newspaper that reported decreased voter turnout and the impacts on public health recommendations have had on local businesses. So here are these public health recommendations, plain and simple. They are stay in place, maintain your space, and cover your face. And I think it's safe to say that these measures are having a positive impact, and we are actually seeing a flattening of the curve since these measures have gone into place. And really, a lot of what we're doing is predicated on lessons from the past. Here's a nice Jama article. Jama stands for the Journal of American Medical Association, on the 1918 influenza pandemic. Now, in this paper, they compare two cities. St. Louis is in the dotted line, and they implemented a pretty rapid response to the influenza pandemic, also known as the Spanish flu, with school closures, banning public gatherings, implementing social distancing and universal masking, versus Philadelphia, which was overcrowded in cramped quarters, continued on with their Liberty Loan Parade, and ultimately took an additional 14 days to implement the same measures that St. Louis had implemented. You can see from the graph that those in Philadelphia suffered twice the death rate as a consequence. And unfortunately, history has a tendency to repeat itself, and we see this now over 100 years later in two districts in Italy, which are adjacent to each other and had two different levels of implementation speed. The one on the left started their shelter-in-place order on February 16th, along with universal masking, while the one on the right started on March 9th, and you can see how the number of cases differed. Bringing this information now locally, here's a curve based on epidemiologists from the Wisconsin Department of Health about how this COVID-19 situation is going to affect Rock County. And in the red, you see the projected number of hospitalized COVID-19 cases if we as a community do not adhere to health recommendations. The yellow line represents moderate adherence to those public health measures, and then the blue line represents very strict adherence, and you can see how flat that curve gets. Of course, the more adherence we get to public health recommendations, the flatter the curves get. The black line represents our projection based on current numbers and activity. So I think it makes sense to just spend a second and tell you locally, briefly, what we've been doing in terms of the COVID-19 situation here at the Beloit Health System. And we've been taking this pretty seriously, moving quickly, organizing rapidly, preparing as much as possible. We started off with a task force, which we formed at the end of January, and then elevated that to a 24/7 incident command center, which is a command and control state for all of our operations, planning, and actions. And any individual member of the Beloit Health System is welcome to attend these meetings, and it does include, at the current moment, representation from every inpatient and outpatient department in our health system. Some local statistics: we've had about 59 cases in Rock County with 4 deaths. We're noticing a little local hotspot, I guess you could say, at the Oak Park Nursing Home in Janesville, where unfortunately 12 of those cases have come from there, and 3 of the 4 deaths unfortunately came from there as well. In Winnebago County, we've had about 113 positive cases and 7 deaths. And in the state of Wisconsin as a whole, right now we're at 3,555 positive cases and 170 deaths. At the health system here, we've developed 5 levels of escalation should a surge occur, with the process really focused on planning for the worst, but preparing for the best in stages with actions that would be executed based on different triggers. Currently, we're in level 2. And as part of that, we have temporarily suspended elective surgeries, and we published numerous protocols and policies and introduced telehealth options. We, of course, have developed a freestanding independent testing center to isolate any patients who might require COVID-19 testing. We've introduced visitor restrictions, staff pre-work screenings, and again, I just want to underscore that I really can't be more proud of our healthcare and our administrative team in terms of the response that we've had. So from here, let's move on to diagnostics and testing, because it really represents a cornerstone strategy for the COVID-19 response, as it aids us in understanding infection prevalence in the community as well as in the hospital in order to prevent hospital transmitted infections. And definitely testing has been and continues to be a pretty acute issue in our country. If you read the papers, one of the key issues has always been the challenges in regards to test availability. The lack of tests early precluded us from truly appreciating the gravity of the situation, from understanding the degree of community spread. And here's a graph that many voicing these complaints refer to. By looking at the tests per million people, you can see we lag behind many other countries. On the other hand, here's another graph, and you can see here we're way ahead. So I guess your perspective on the issue of test availability really depends on which graph you're focusing on. I think there's no question that everybody is doing their absolute best to see us through this crisis, and that the more tests we do, the better we all will be. In terms of diagnostic tests that we have, they mainly involve reverse transcriptase PCR tests, which is a process in which we're able to detect components of the viral genome. And in particular, this test targets two key locations of the viral genome. Highlighted here in red, you have the N gene, which codes for the nucleocapsid protein, and then you've got the E gene, which codes for the envelope glycoprotein. Now, those are just two components of the virus. And the SARS-CoV-2 virus is a large enveloped positive sense single-stranded RNA virus. And again, these two specific locations on the anatomy of the virus are like two little fingerprints that we use to identify it. And I think it's really important for everybody to recognize that there is no what we call cross-reactivity between the SARS-CoV-2 virus PCR test that we use and the other four common coronaviruses that circulate in the world. And what you see here is something called a phylogenetic tree, like a family tree, demonstrating the genetic relationship between the different types of coronaviruses. What you see is that there is divergence between SARS-CoV-2 and the other common coronaviruses. In other words, SARS-CoV-2 is kind of like that family member that doesn't quite fit in because of its slight uniqueness. And we can utilize that uniqueness in order to better identify it using our reverse transcriptase PCR tests. And that's something that we refer to as having a higher sensitivity. And I guess in regards to sensitivity, reverse transcriptase PCR tests vary based on where the test is conducted or the sampling site. So here's some data on sensitivity based on sampling site for the common coronaviruses. Again, not the SARS-CoV-2 virus that causes COVID-19. This slide is about the common coronaviruses. So sampling of the oropharyngeal region, that's the first picture on the right-hand side, the top right-hand side, seems to have about a 56% sensitivity, while the nasopharyngeal region, that's the photo in the top right-hand side of the screen, slightly better at about 76%. And as you might expect, if you do both of them, it'll boost the sensitivity even further. A nasopharyngeal wash, which is common in pediatrics, offers the highest sensitivity at 89%, and that's pictured on the bottom right. Well, moving on to the SARS-CoV-2 virus, there's not too many studies out there that's been completed to allow us to calculate the sensitivity, but we do have several studies that look at the percent of positive results based on location site. And we see a similar trend in these preliminary reports with oropharyngeal sampling at the lower end, nasopharyngeal slightly higher, and then sputum studies, which is getting more attention in the news recently, and even more invasive test called a bronchial alveolar lavage, or BAL, and that's pictured in the bottom right-hand photograph. The study I cite here at the bottom of the slide does have some notable biases in that many of the patients had severe disease in the study and got more bronchial alveolar lavages than others, but nonetheless helps provide us with an early indication as to what type of sample might be the best approach. There's some exciting new developments in the diagnostic front that have come online recently, and the picture there on the left is the Abbott instrument, the ID Now. It uses an isothermal amplification approach that provides a yes-no answer in under 10 minutes. And this could have great potential for places like the emergency room, outpatient clinics, to determine if a patient has COVID-19. The only potential concern that I see with that machine, however, is that the instrument does have the ability to aerosolize the sample, and so extra caution has to be taken when utilizing it. Now, the one on the right-hand side, however, is the Cepheid Expert Express platform, and again, another PCR instrument that analyzes swabs from the nose or the mouth. It's a 45-minute sample in to answer out machine, and provides us an answer to whether or not a patient might have COVID-19. And I'm really excited to tell you that we've got this here at the Beloit Health System. These machines, again, use the swabs. They have the ability to amplify the sample, so even if you're able to get a small amount of virus on a swab, it would be detected in these machines. And the machine allows us to run multiple tests at one time, and we've gone ahead and validated the machine here at the health system with the positive-negative agreements reaching 99.9%. And the only limitation we have right now are the number of cartridges that are being supplied by the company Cepheid. So widespread adoption of this, unfortunately, is currently not available, but these machines definitely represent important developments that will improve our workflow to rapidly identify patients with COVID-19 and implement necessary infection control precautions to triage resources. Well, here's some really interesting data from Hong Kong that was published in The Lancet, which reveals something pretty interesting about the virus. Look here on the left side of the graph, the y-axis, the viral load, which I've circled in red. The higher the viral load, the more contagious it is. On the bottom of the graph, that's time after symptoms, here measured in days, and I've circled that in black. And what you see is that regardless of how the sample was obtained, in this case, the researchers used sputum samples in blue, and they used endotracheal aspirate samples in red, and that just represents samples obtained from the lower respiratory tract. The point here is that the viral load was highest early in symptom onset and declined as time went on. This is really significant, and it's notably in contrast to all of the other coronaviruses that we are aware of, where the viral load generally peaks after symptom onset, not before or right in the beginning of symptom onset. So with SARS-CoV-2, this very high viral load in patients who could have mild symptoms, or when the disease is just beginning, or perhaps even before the disease is showing symptoms, likely is contributing to the rapid spread of infection in people who are asymptomatic and minimally symptomatic. More insight on this important topic of asymptomatic spread and asymptomatic individuals who might be positive for COVID-19 can really be learned from what happened on cruise ships. So, you probably recall the Diamond Princess cruise ship, which was docked off of Yokohama in Japan. It made headlines because 19.2% of passengers and crew tested positive, but most notably, 50% of the individuals that tested positive were asymptomatic at the time of the test. Unfortunately, in total, we had over 700 confirmed cases on the ship and 12 deaths. You might also be aware of the Grand Princess ship, which was docked off in Oakland. And the first 42 individuals tested, there were 21 positives. They eventually got up to 103 positives with over 300 tests still pending. You might ask at this point, why are cruise ships such fertile grounds for COVID? Well, it's not just COVID. You might recall previous reports of outbreaks of things like norovirus, even influenza on cruise ships. In general, infections can gain ground on cruise ships for several reasons, but I think the one that I find the most interesting is due to the air circulation systems on ships, which don't have HEPA filters, in contrast to airplanes, which do have HEPA filters and can filter these particles out. This is kind of a concerning study, and in this paper, they looked at 55 patients. Family members of known COVID-19 patients were those that were studied. And the researchers here did viral swabs, again, on the family members of COVID-19 patients. And they found that those individuals were actually positive for COVID-19 up to 7 days before they developed any symptoms. And it turned out in this study, the younger people had more mild symptoms. And I think what was most striking about this study is that they went ahead and they did CT scans on patients who reported no symptoms, and 71% of them had abnormal CT scans when they were feeling totally healthy. A little talking about serologic testing or blood testing, which is really an emerging area of a lot of interest. It's going to help us in so many ways to detect if a person was exposed to COVID-19 or any other pathogen, as our body, as you know, develops antibodies when infected to fight that disease. And it's helpful always to step back and ask, what are the goals of serologic testing and the added value to what we just discussed, the nucleic acid reverse transcriptase PCR testing, which is the fancy way of saying swab testing. So there are several important benefits of blood testing over swab testing. The most significant is simply determining the presence and the duration of protective immunity, which could have important implications for triaging the ability of individuals like healthcare workers to return to work. It can also have a role in evaluating the efficacy in vaccines and the durability of those vaccines. Serologic testing will definitely be key for enabling population-wide seroprevalence studies to be able to determine precisely what the prevalence is and a better estimate of those mortality rates. So with the swabs, or the nucleic acid reverse transcriptase PCR testing, a negative testing that's obtained is in an individual in which the clinician feels has a high pretest probability, does not rule out infection. In other words, just because you get a negative COVID-19 result after swabbing someone's mouth or nose does not mean that they do not have the disease, but serology testing can ultimately determine the validity of those tests. And it's encouraging really to see that there are over 70 test developers currently pursuing serology testing. And some progress has really been made on this testing. There are a few already available. And for the scientists in attendance, here's a general diagram of exactly how they work using laminar flow. Especially the assay currently being marketed by Becton Dickinson. These are assays that use colloidal gold nanoparticles affixed to part of the strip that you see there on the top left-hand corner of the screen. And if a patient has antibodies against the SARS-CoV-2 virus, those antibodies will bind to those gold nanoparticles containing antigens or representative samples of SARS-CoV-2 virus. And depending on if there's IgM or IgG present, there will be binding at specific locations as the patient's blood sample is flowed through this assay, kind of like a car moving through a car wash with different stations to areas where there are IgM or IgG present. It'll give a similar readout to a rapid strep test, where there'll be a banding pattern seen on the top right-hand corner of the screen that can be easily interpreted. And again, these tests, unfortunately, are not broadly validated yet, so utility is still in question, but this is really an exciting development, and I think all of us can't wait for it to become available. Really cool and nice work out of Mount Sinai. They were further investigating our understanding of serologic testing. And one of the issues with rapid blood testing is the cross-reactivity that it could have with those common coronaviruses. The group at Mount Sinai actually built an ELISA, or an enzyme-linked immunosorbent assay, that went ahead and targeted the spike glycoprotein binding domain, which is shown here in red in this model structure. And this ELISA was specific for SARS-CoV-2. Again, this is a fancy way of saying, again, we have a unique fingerprint on this virus that will allow us the ability to use serologic testing to differentiate between seroconverters and control samples. And just to clarify and remind everybody what I mean by the word ELISA, or enzyme-linked immunosorbent assay, I'm referring to this process in which we have a plate that's coated with viral particles here on the left, and the RBD in CoV-2 spike RBD. The RBD stands for receptor binding domains on the virus, and we call those particles, again, antigens. We introduce the patient's blood onto the plate. If the patient has been exposed to COVID-19, they will no doubt have developed antibodies, and those antibodies to the virus will then be introduced on the plate and bind to the antigens. Once that occurs, we can add a flare, so to speak, to it to pick it up, and that's what we scientifically refer to as a detection agent, such as IgM or IgG, and that has a color enzyme coupled to it that can emit a color, and we can read that out using a spectrophotometry machine, and that'll allow us to identify the presence of antibodies and then yield the result. Really important to consider the role, again, of serologic testing in the broader context, especially the time that's needed for individuals to seroconvert or show evidence of infection in their blood, evidence of a response to an infection. The serologic or blood testing may not be best for detecting an acute infection, based on this really incredible paper published in Nature just a few weeks ago, in which seroconversion occurred in 50% of the people that had mild or moderate COVID-19 disease on day 7, not on day 1. And 100% of the individuals converted on day 14, highlighted here in blue. In other words, if you took a blood test at day 1 or 2 from an individual who had COVID-19 infection, the result would likely come back negative. But then on day 7, we'd have a 50% chance of seeing that, and then by day 14, we'd have a 100% chance of seeing it. Now, also important here is the work beneath the graph, where you see data looking at relationships between positive viral cultures obtained from those swab specimens from patients over time. And what these researchers found, which is really incredible, is that in these patients, after day 8, circled here in red, there were no patients in the study that had culturable live virus that could be obtained by swab samples. And again, presumably that's a reflection of the presence of neutralizing antibodies in the sample that correlate with the antibody response. This is also a really great study, as it highlights the reality that we can get false negatives for viral testing by PCR or swab testing. In other words, when you test somebody by using a swab and it comes back negative, it could be wrong and the person could actually be positive. And that can be due to a variety of reasons. Number one, maybe you missed the window, like we just saw in the previous graph, of viral replication. Number two, maybe the sampling was inadequately performed. So this group, they used assays using the IgM and IgG detection agents. And if you look here at the top left graph first, what you see is IgM is depicted in red, and it starts to go up and has a higher level of positivity at around day 5 compared to the nasal swab depicted here in black, which starts to come down. Now look at the next graph down, the one that looks like a donut. This is really, really amazing. This represents patients whose swab test came back negative, but then when they did blood samples on those patients, 93% of them had positive IgM or active disease. So then the final last graph is basically saying, because of what they found, the use of both mechanisms, a swab test and a blood test, or PCR and an IgM ELISA, gives you a 97% chance of detecting the virus. So again, a combination is more robust. Again, we're just looking forward to serology testing becoming more available. It's certainly limited throughout the nation. Employed Health System is aggressively pursuing it, and we anticipate that we're going to actually have it here live within a month. One last testing apparatus that hasn't gotten much attention but is really worth knowing is metagenomic next generation sequencing, and it's current technology largely used in research labs and major academic institutions, in which in this case you can take any sample, such as a swab, respiratory sample, anything, and extract the nucleic acids from it, isolate it, and detect every microbe present in the sample in a completely unbiased approach, basically allowing you to see everything, like in the movie The Matrix. This approach was actually what was first used to identify SARS-CoV-2 back in Wuhan, when they didn't know what was happening and they thought it was just some idiopathic pneumonia syndrome. I predict that in the years to come, this is going to become more widely available across the country. Okay, well, let's move on and discuss the clinical manifestations of COVID-19. And to give you a high-level summary of the main systems impacted by COVID-19, we're going to highlight the eyes, nose, mouth, cardiac, GI, respiratory systems, and then a special mention for cancer patients, pediatric patients, and then critically ill patients. Let me first, though, start off with common radiology and lab findings that we should expect in COVID-19 patients. And the chart here on the right is information based on a New England Journal of Medicine article that looked at 1,100 patients in China. It was a cohort study. On admission, the clinical phenotype of these patients basically had, the majority of them had abnormal CT findings, as well as lymphopenia. About 2/3 had an elevated CRP. 1/3 had low platelets. Procalcitonin elevation was not very common. LDH, we should definitely think about that. 20% had abnormal AST, ALT, or liver abnormalities. Very few had bili elevations. And you may have noticed I skipped over D-dimer because I want to just highlight and underscore that, because I think as clinicians, we need to be paying particular attention to D-dimer, because the D-dimers, when they were elevated in patients, they had those patients had significantly much more severe disease and higher mortality. Here's a slide of the most common clinical presentations of COVID-19, and we know this is a very heterogeneous disease, ranging from asymptomatic to mildly asymptomatic in about 80% of patients. And this data here comes from another cohort study of 44,000 patients in China, published in Jama and New England Journal of Medicine. About 14% will have severe disease with spontaneous recovery, and then there's an unfortunate about 5% that develops severe disease with acute respiratory distress syndrome, or ARDS, and most unfortunately die. In general, in regards to symptoms, this list comes from a series of hospitalized patients, and so fever used to be pretty high, but it turns out it's not as common as we originally thought. And then cough, myalgias, fatigue, sore throat. Here, nausea, vomiting, and diarrhea was initially reported to be around 3 to 10%, but there's actually been some newer studies suggesting that it could be as high as 50%. And then, of course, listed here, headache, rhinorrhea. Also, just mentioned loss of taste and smell. That's getting a lot of attention, and we're going to touch upon that in just a few more slides. This slide here, I just include for reference, reviews risk factors for severe disease with patients who have COVID-19. And this is what has been used and is being used at the Massachusetts General Hospital. One of my former colleagues there provided it to me, and I thought I'd just share it with you all just for reference. Of course, the main system we want to review is the respiratory system. So the clinical symptoms from a pulmonary point of view include shortness of breath, difficulty breathing. And this article from the Philadelphia Inquirer singles out ARDS as the culprit, or acute respiratory distress syndrome, as the culprit of most of the mortality related to COVID-19. ARDS is a patient with acute respiratory failure, difficulty breathing. Bilateral chest infiltrates will be seen on the chest x-ray. Protein-rich pulmonary edema. It's a non-cardiogenic pulmonary edema. Of course, the PF ratio has got to be less than 300 millimeters of mercury. And remember, the PF ratio represents the arterial PO2 divided by the FiO2, or the fraction of inspired oxygen expressed as a decimal that the patient's receiving. ARDS has a mortality of 40%. Generally depends on the initial degree of hypoxemia. And prior to COVID-19, we were seeing about 200,000 cases related to a variety of clinical disorders like pneumonia and sepsis, aspiration, and even trauma. Here's actually a classic X-ray and CT scan side by side of the lungs, showing extensive infiltrates on the X-ray on the left, as well as what's called ground glass opacities, or an appearance on the CT scan on the right. Just a little bit on the ground glass appearance. That's really based on the disease process. So on the very top left is a healthy and normal pneumocyte, or lung cell, along with its correlating appearance on lung CT beneath it. The second picture from the left shows what happens in early infection when the virus inhabits the pneumocyte, and you begin to see this release of cytokines. But again, beneath that, you see the lung CT is essentially unchanged at that time. Now in the third picture, you see the pneumocyte starting to fill up with fluid from all those cytokines that have been released. And beneath it, you're starting to see that classic ground glass appearance on lung CT. And then lastly, in the fourth photo, when the cell completely fills up, it becomes consolidated, and beneath that you'll see the appearance on lung CT. The term ground glass, and there is some ground glass there pictured on the right-hand side of the screen, has been used to describe this finding since about 1996 as a way of descriptively highlighting this hazy, increased attenuation of the lungs. Lung pathology is really interesting. The classic features of ARDS include protein-rich edema, fibrin debris, as many of you know. What's unique here in ARDS for COVID-19 patients is the presence of mononuclear cells, including lymphocytes. And you can see the extent of the injury. Here, the alveolar epithelium is nearly denuded. And a recent publication also suggested that there is presence of viral inclusions that can be noted on some samples. So keep in mind the lymphocyte mononuclear collection, truly a unique feature that's being seen on pathology. In regards to the cardiac manifestations, there are several clinical syndromes that have been identified in COVID-19 patients, such as myocarditis and myopericarditis, or inflammation of the heart lining, and tamponade, or pressure that's placed on the heart for a variety of reasons. And some of these have been fulminant, leading to death. There's been a lot of discussion about the prevalence of cardiomyopathy, which came out of this Evergreen study in Seattle. It was an ICU study of about 21 patients, and they found that 7 of them had cardiomyopathy. Now that was countered by another study, a multi-center ICU study also out of Seattle, which found 0 out of 9 patients had cardiomyopathy. So again, the true incidence of cardiomyopathy is not yet known, but we just need to place it on our radar. Arrhythmias have also been noted in anywhere from 6 to 17%, but again, the exact type of arrhythmia is not really known. There have been 2 really high-profile papers in Jama and Jama Cardiology talking about the association of cardiac injury with adverse outcomes. Both were clinical studies based in China, with one study that had 187 patients and another with 416 patients. They showed cardiac injury was described in up to 30% of patients, and the definition of cardiac injury was elevated troponin, and that's irrespective of any EKG changes. So they found that cardiac injury was more common in patients if they had pre-existing cardiac disease. Another study from the New England Journal of Medicine showed that high sensitivity troponin levels were associated with a higher risk of death. Cardiac injury was associated with increased risks of complications, again, arrhythmia, ARDS, intubation, and even acute kidney injury, as well as increased associated inflammatory markers like white blood cells, CRPs, again, D-dimers, and an increased overall risk of death up to 10-fold. Now, the authors of these papers hypothesized that the cardiac injury likely was secondary to either direct infection or inflammation, or even possibly demand. And I also want to mention that this isn't too unique. Respiratory viruses like influenza have been shown to have an increased risk of MI, thought to be due to inflammation. And so you might ask, should we be ordering troponins on all COVID-19 patients? Now, we do have some current guidance from the American College of Cardiology, the ACC, which is to measure a troponin or natriuretic protein only if the diagnosis of an acute MI or heart failure is being considered. Here's just a summary slide on the different cardiac manifestations associated with COVID-19 for your reference. A lot of attention to these medications, these ACE inhibitors and ARBs that many people are on. The ACE2 receptor is the SARS-CoV-2 cell entry receptor. In other words, that's the door that the virus uses in order to gain access to our cell. It goes through the ACE2 receptor. And it's unclear if ACE inhibitors would actually worsen or improve COVID-19 disease. And the reason for the back and forth debate is that ACE inhibitors, when used, actually upregulate or increase the number of ACE2 receptors. And of course, if there are more receptors, there's going to be more ability for that virus to get into the cell. Now, the counter argument is that ACE inhibitors help pulmonary disease by decreasing pulmonary inflammation. And there's some animal model data from SARS-CoV-1 back in the early 2000s that would actually support that. Currently, the recommendation from multiple European and American societies are saying that individuals who are already on these medications should remain on them. And of course, you'd imagine, and there are many clinical trials underway of recombinant ACE2, as well as medications such as losartan. So more clarity on this issue is certainly going to be forthcoming. Okay, we mentioned GI manifestations, so let's get into it a little bit here. Nausea, vomiting, diarrhea, those are the main symptoms. And as I said, initially we thought this was relatively uncommon because 1 to 10% of patients were reporting them in most large clinical case series. But there have been some newer reports that are suggesting a much higher rate of diarrhea as a symptom of COVID-19, as high as 50% of the time. Now, there are some atypical cases where patients will have GI symptoms and never develop any respiratory symptoms, but that's only been seen there was 2 case series that actually observed that. One of them had 204 patients, the other one had 1,141 patients, both based from China, and they found just about 3 to 10% of the time patients had GI symptoms and no respiratory symptoms. So again, there's definitely going to be much more discussion about this coming, and certainly important, again, just to put it on your radar to look out for as you're evaluating patients. So let's start looking at the eyes and the mouth and the nose. Recent article in JAMA Ophthalmology, it's a study out of China again, that found that 12 out of 38 patients, or 32% of patients, had ocular manifestations, and that included things like conjunctivitis, where they found chemosis or swelling of the conjunctiva, conjunctival hyperemia, or increased blood vessels in the eye, and epiphora, or watery eyes. These were found mostly in moderate, severe, or critical illness in patients with COVID-19. One patient had epiphora as the first symptom of COVID-19, and 2 out of 11 had positive conjunctival swabs, so where they swab the eye for SARS-CoV-2. One of the accompanying editorials to that article just point out that they said from an epidemiological point of view that there could be transmission of the SARS-CoV-2 virus through the eyes. And a lot of attention then, as we move on here to the mouth and nose, has been recently paid to this loss of taste and smell that's being reported as a potential clue to COVID-19. And there is one published paper in Clinical Infectious Diseases journal. It was a cross-sectional study of 59 hospitalized COVID-19 patients in Italy. And they found that patients had olfactory or smell disorders in combination or separately from taste disorders in about 34%, or 20 patients. And patients that had just a taste disorder was 10%. And that was really with dyschezia, or a mild diminution of taste, over ageusia, a complete lack of taste. Now, olfactory disorders alone were seen in about 5% of patients, and those individuals had hyposmia, or partial loss of smell, with no anosmia, complete loss of smell. And then a mixed taste and olfactory smell disorder was seen in about 19% of the patients. Many of these had, again, anosmia, or complete loss of smell. These disorders were notably more common in women and younger patients. And all the patients had persistent symptoms at the time of the survey, which was done on day 15 of the symptoms. Anecdotally, we have heard that patients have had improvement of these symptoms over time, fortunately, so the loss of taste or smell is just temporary. Mechanism for this is still unclear. We think it could be due to direct infection, as was done with SARS-CoV-1. It had the ability to infect the cells of the nose, versus possibly, again, being due to inflammation, as there are ACE2 receptors in the nasal and oral cavity. Quick mention here of COVID-19 in patients with cancer, and there's really 2 large papers discussing this. One was in JAMA Oncology. It looked at about 1,500 patients admitted to a cancer hospital in Wuhan, and found that 12 patients had COVID-19, or 0.79%. And while that may not sound like much, it was twice the community incidence, which was 0.37%. Of those patients, 58% of them had non-small cell lung cancer, and 42% of them were on active chemotherapy or radiation, and unfortunately they had a 25% mortality rate. The other study was in the Annals of Oncology, and they looked at clinical features of 28 cancer patients with COVID-19. Again, lung cancer was the most common in these series. A third of patients had stage 4 cancer. 21% of them were on chemo or radiation within 14 days, and those patients had a higher risk of severe disease. In that study, 29% of the patients actually acquired COVID-19 while they were in the hospital for another reason and had a 30% mortality. Again, now the interesting points here are the high incidence of lung cancer in both studies and the high mortality rate. And I think it's logical, given that COVID-19 infects the lungs, and if an individual is already compromised secondary to cancer of the lung, likely they will subdue to the disease more than others. In terms of a question about co-infection, and this is a question of, can you have the flu and COVID-19 at the same time? There's data that's come out of China and Singapore that suggests that only 0 to 6% of the time that happened. In the US, there's been a few studies that have just kind of trickled out, and of the 3 studies that have been done, again, the range is low, about 0 to 14%. So it's still a little unclear. There's been no large study that's been really evaluating this, but at the current moment, we don't believe that this is really very, very common. Okay, in terms of pediatrics and COVID-19, this is an article from the journal Pediatrics, in which you can see the vast majority of children who've had COVID-19 have mild disease. Now, since we're only testing people in the United States who are symptomatic, keep in mind most children are not going to be tested. So there's really not much data out there about the pediatric population. But I want to underscore that this is an important segment of our population to focus on. Because as you look here, for the few studies that have been reported, there are a low number of cases in our pediatric population. But in this study that was published in the journal Nature, there was a study of 10 kids with confirmed COVID-19, and these kids had very nonspecific, again, very mild symptoms. They didn't require any hospitalization, and they swabbed their nose, and you can see in that top graph, their SARS-CoV-2 virus load was coming down nicely. But what's interesting here is look at the bottom graph. And you can see the SARS-CoV-2, which was swabbed from the rectum in the stool, was lasting for almost a month. So they were able to find virus that was persisting for a longer period of time. And that's really important because, again, minimally symptomatic pediatric patients could actually serve as a source of environmental contamination for this virus and enhance the spread of it. So I think the big question many people are having is, why are children only getting mild disease? There's no real clear answer to that. It could be because they've got healthier lungs. Obviously, they've got less comorbidities in general, so they get sick less. There's also a theory out there about age-related differences, again, in that ACE2 receptor, the receptor that SARS-CoV-2 uses to get into our cells. And remember that ACE2 receptor, if it's low, you're not going to have much SARS-CoV-2 coming in. So again, more information on this to come, I'm sure. A very interesting segment of the population that we've got to keep our eyes out for. Okay, and with that, I want to say caution ahead here. This is where things get a little serious as we talk about patients who go into the ICU. And we're going to talk about a concept called the cytokine storm. Let's look at the clinical course and the associated mortality rates for COVID-19 patients that unfortunately land up in the ICU, and you'll understand why there was so much concern for Prime Minister Boris Johnson when he was admitted to the ICU in England. So in terms of studies, those coming out of China, there were about 3 studies of critically ill patients that showed about a 60 to 78% mortality rate. And if the patient was intubated while in the ICU, they reported a mortality rate of 80 to 100%. In the US and UK, we've done several studies. In the US, the Evergreen study in Seattle, one study had 28 patients in the ICU. 71% of them were intubated, and they had about a 67% mortality rate. In another multi-center ICU study from Seattle of 24 patients in the ICU, 75% of them were intubated, and they had a 50% mortality rate. So our data shows better mortality rates than those in China, but still overall very high. In the United States, our average length of stay in the ICU was 9 days. In the United Kingdom, one study of 196 patients with 75% of them being intubated in the ICU, pretty consistent with the US data, 48% mortality. Their length of stay was 3 days. A lot of anecdotal now clinical observations about this concept of a cytokine storm in critically ill patients. And this has been driven by reports that severe disease and death is associated with higher inflammatory markers like the white blood cell count, the CRP, the D-dimer that we were referring to, the ferritin, the IL-6, TNF-alpha. Not totally clear what the pathogenic role of these cytokines are, but there's a lot of growing interest as to whether we should target them as a therapeutic strategy. And the way to think about that is when an infection occurs, our body begins to attack that infection by sending out chemicals or cytokines to destroy it. The longer or more aggressive an infection is, the more cytokines our body emits. And in mass, these cytokines are very effective at killing the target, but unfortunately also act sort of like a bull in a china shop, with the inevitable damage of nearby healthy tissue and organs, causing additional injuries that a patient may not be able to recover from. These injuries can be so bad that it can actually potentially result in the patient's demise. So the reason we're looking at this is maybe a treatment for COVID-19, ironically, would be to weaken our immune system. And we're certainly considering this approach, and you're going to hear more about this certainly as time moves on. This is a great article actually written by one of my friends out in Boston, and what Hassan, the author, here is reviewing is the overall pathogenesis of COVID-19. In stage 1, on the left, you have a lot of asymptomatic people, or people with mild cases. Maybe they've got low-grade fever, cough, diarrhea, that's noted in the blue box right below, a headache in the early stages. As you move into stage 2, and he's divided it into 2A, which is non-hypoxic, and 2B, which is hypoxic. Over about a week's time span, a person can go from having no symptoms to being incredibly short of breath. And this is the rapid decompensation that many have been so concerned about. And this is where more lab abnormalities and inflammatory cytokines being released will be noted. And that's where you see the host inflammatory response phase, or the cytokine storm, where you get that increased mortality. So as this relates to treatment, the theory is that antivirals will work in the early stages of disease, where you see the blue triangle, and that in the later stages of disease, where you see the orange triangle, that's the more inflammatory stage, where we have all of our cytokines in play, and perhaps things like steroids or other anti-cytokine therapy should be focused on. And I guess that's a pretty good transition to discussing treatment options. And we can essentially just divide it up into exactly those two buckets. There are either going to be treatments that target the COVID-19 life cycle, the viral life cycle, and those treatments would stem the tide of the disease, or there's going to be treatments that target the immune response to blunt the inflammatory response that we've been talking about. So let's look at an example of a treatment, remdesivir, that really is looking at the COVID-19 life cycle bucket. This is a nucleotide analog, and it inhibits RNA-dependent RNA polymerase. So in this schematic here, you can see it would block the activity right here in red, thereby preventing the virus from replicating in our cells. And in vitro, remdesivir has really broad antiviral activity. There are a handful of clinical case series published that include a few patients treated with compassionate use, There have been no firm, really good conclusions that have been drawn. There weren't controlled studies. We have 5 randomized large trials underway, and we anticipate the first results coming out of China really soon. Unfortunately, the medication right now is not widely available, and more data is needed, and applications need to be submitted in order to be given permission to get this medication. Hydroxychloroquine has been an increasingly common topic of discussion, and it's an antiviral medication, but also an anti-inflammatory medication, and there have been 2 randomized trials in China that have analyzed this medication conducted in mild disease. And again, as a caveat, any study that studies mild disease, you want to remember that most patients get better and they have a steady natural decline in their viral load by culture and PCR. So we got to be really careful when drugs are given to individuals with mild disease and then a study reports that the patients got better and their viral load went down, because we would have expected that to happen with or without the treatment. This first trial, however, had 30 patients. They got 400 milligrams of hydroxychloroquine daily compared to standard therapy. And in that study, the standard therapy included a wide variety of antivirals, and many patients had more than one of the treatments, including inhaled medications and oral medications. The study was open label. 80% had mild disease. Primary endpoint was day 7 PCR testing. 13 of 15 patients, or 87%, on hydroxychloroquine had undetectable PCR. And 14 of the 15 patients in the control arm, or 93%, had undetectable PCR. Again, no big difference in clinical outcomes, but fortunately no safety or adverse events were reported either on those people that were taking hydroxychloroquine. The second randomized control trial had 62 patients. Again, 400 milligrams of hydroxychloroquine was the dose given daily versus standard therapy, defined in the same way. It included a whole variety of antivirals. It was not a controlled study. A little unclear from reading it if it was blinded. This study was, again, mild illness. Primary endpoint was clinical status of day 6. There was actually no PCR testing done here. What they found was that there was a 1-day reduction in fever and cough in those patients who were treated with hydroxychloroquine. 4 patients progressed on to severe illness in the control arm, and 2 individuals had a drug reaction to hydroxychloroquine, but it was not a QT prolongation. Can't conclude much from these studies. It mirrors, again, the natural history in terms of clinical recovery and virological decline that we would expect in individuals without treatment. So I think the only important thing we can glean from it is there was limited safety concerns from these medications, and I think that is an important conclusion to draw. Another important point is, what's the right dose of hydroxychloroquine? And this graph shows that perhaps 400 milligrams daily might be too low to get above the extrapolated patient EC50, or the concentration of a drug that gives half maximal response, which is what would be the pharmacologic target. So a higher dose of 600 milligrams twice a day would get us above that threshold and hopefully be below where we might see QT prolongation. Well, how about hydroxychloroquine and azithromycin? There's some intriguing data from France that showed that this combination reduced viral load more quickly. In a follow-up study from the same group, a single-arm, uncontrolled study of about 80 people, mostly with mild disease. Here they had hydroxychloroquine 600 milligrams daily and azithromycin. The black bar on the graph in the middle shows those that got virological testing, while the tan bars are undetectable at those time points. And you can see that the trend in general was going down, as well as the cultures, which showed a negative trend. So most of these patients did well. 3 were transferred to the ICU, 1 stopped, 65 had to be discharged. And again, we expect these people to do well since they had mild disease, so it's hard to say what the role of hydroxychloroquine and azithromycin was in this study. They had a follow-up study. This was a different French group, and it showed contradictory results. It was a small study, single arm, uncontrolled, 11 patients, same regimen, and they actually noted worse outcomes. One patient died, 2 patients were into the ICU, 4 patients had QT prolongation, 1 stopped the drug, and most patients were still PCR positive at day 6. And they concluded, quote, that there was no evidence of rapid viral clearance or clinical benefit, end quote. So I guess where does that leave us? It's unclear if hydroxychloroquine has any efficacy. The dose is uncertain. The role of azithromycin also unclear. And to sort this out, of course, we're going to need robust randomized clinical trials, and that's going to take time. Again, the important thing here is let's at least glean that their concerns about safety are minimal with these medications if monitored properly and dosed appropriately. Here, however, is a really interesting article that came out from another group in France. This was a study, a non-randomized, open-label study, and it comes with some caveats. Small, 50 patients enrolled. People who had confirmed COVID-19 were offered hydroxychloroquine, and then they were either given azithromycin or they were not given azithromycin at the discretion of the physician. Those that declined hydroxychloroquine were in the control group, and that, of course, introduces a lot of biases. But with that said, let's look at the study and the results. In the control arm, which is represented here on the graph in black, 16 patients, the viral dynamics over the 6 days, you can see the quantitative PCR of SARS-CoV-2 really didn't go down. But those given hydroxychloroquine saw a decline in the SARS-CoV-2 viral load shown in blue. And then when you added azithromycin, shown there in green, only 6 people were in that group, but the viral load came down, and it came down fast. Again, we need to interpret this with great caution as it wasn't randomized, but it certainly shows a promising signal. Just to highlight here, the dose that was given of hydroxychloroquine, again, was 600 milligrams for 5 days. Another really fascinating topic is convalescent plasma. And convalescent means a person who's recovering from an illness or a person who has recovered. And here we're talking about using blood from those individuals that have recovered from COVID-19 as a treatment. And this is an antiviral strategy that's been around for a really long time. One of our oldest interventions, actually. We saw it being utilized in the 1918 Spanish flu outbreak and the H1N1 outbreak, and it significantly helped to reduce mortality. It was also used in SARS and MERS, and the suggestion is that earlier treatment with this is more efficacious. There is some anecdotal data to support use in critically ill patients as well. In COVID-19 patients, we see here in this Jama article that 5 patients did really well when they were treated with this. Of course, we're going to need more data. We do have an FDA emergency IND, or investigational new drug application, for severe or life-threatening disease, and this will certainly help us give access to patients who might need it. Other areas where this could be useful is to provide post-exposure prophylaxis for high-risk individuals and healthcare workers. One really important point is that as we start to see these patients getting well and leave the hospital, we should really be encouraging them to donate blood, as this could be used to provide convalescent plasma to help others. And that is something we are doing here at the Beloit Health System, and we are looking for blood donors from patients who've recovered from COVID-19. Okay, moving on to the other bucket, immune modulation. This article really summarizes a lot of it. And so let's look at the first column, the green column. It represents an uninfected individual. If you look at the very top here, I'll circle this in red. Those are our cells that are in contact with the exterior world. And down below, I'll circle that in blue, you see some blood vessels. And you see in those blood vessels are numerous purple and green circles representing CD4 and CD8 cells, sort of like our body's first responders that would exit the blood vessels and come into the space in between the two circles to meet any threat head on. Okay, so now let's move on from the green column to the orange column. And that represents an individual with moderate COVID-19 disease. Now you can see some of the virus represented by those little red balls. They're infiltrating our body. And we're beginning to send out initial cytokines with increased immune activity with IL-6, TNF-alpha, IL-10 in response. And you could say that the battle begins. Now move on to the red column. And this represents an individual with severe disease in something called, again, the cytokine storm, an elevation in many other cytokines. And as our body responds with great force, that not only damages the virus, it will again also have the potential to damage our own tissue. So this science has led to a lot of interest in using immune modulators such as IL-6 inhibitors, IL-1B inhibitors, JAK-STAT inhibitors, CCR5s, steroids, to which the jury is still out, to dampen the robust immune response and minimize the damage to our own normal tissue. But we don't know what to target. Is it just one of those pathways? Is it a combination of those pathways? We don't know what the optimal timing is. Is it for critically ill patients? Could we potentially even hurt patients with COVID-19 by suppressing their immune system, allowing their disease to flare? So these are still questions that need to be answered, and I would expect much more on this to be coming out in the near future. There are many other therapies under investigation. In fact, the World Health Organization website lists 400 different trials currently underway. Just to quickly highlight a few more for us, ivermectin, it's an FDA-approved antiparasitic medication commonly used to treat scabies. A recent in vitro study found that ivermectin stopped COVID-19 from replicating and is due to ivermectin's ability to prevent an infection from transportation into the nucleus. Zinc has also been mentioned as it serves to assist our immune system in mounting an adequate response to infections and has been shown to reduce the incidence of respiratory infections, shorten the length of those infections, and improve the rate of recovery. Vitamin C has also been involved in a very favorable phase 2 trial published in Jama, and more information is definitely going to be coming out of that in the very, very near future. This slide here and the next slide, just really good references from JAMA highlighting the different treatments currently being pursued, along with detailed information on dosing protocols, contraindications, side effects, and special considerations. And then I want to talk to you about the vaccine. Immunity to the cold-causing coronaviruses are actually pretty limited, but we also know that those viruses are mostly upper airway diseases. Lower respiratory diseases like SARS and MERS, they have a more durable immune response, and it suggests COVID-19 will likely do the same. There is a number of major approaches. The World Health Organization has a nice website on this. There's 8 different approaches that are being pursued. There's currently 47 different candidates out there with 2 human safety trials already underway, a Derna vaccine, that's an mRNA subunit vaccine, and a Cansino, which is looking at the adenovirus vector. Always hard to rush vaccine therapy to market. I anticipate probably we're looking at 12 months until it becomes widely available. And of course, when it does, I think it'll be received very warmly. If you have some time, here's a couple of great books that I think are worth the read. The one on the left, The Great Influenza by John M. Barry. He's a prize-winning and New York Times best-selling author. The book was actually named the year's most outstanding book in science and medicine in 2005 by the National Academies of Science. And I know it's become a standard must-read for medical students since its publication. And if you have a lot of time on your hands, I'd suggest looking at the book on your right, The Coming Plague. It's by Laurie Garrett. It was published in 1994. It's 800 pages of fun and pure history. But Laurie is a Pulitzer Prize-winning journalist, and In this book, in 1994, she sounded the alarm for the eventual development of a worldwide pandemic. Each chapter of the book actually highlights a different outbreak and that was managed, and you can almost view it as being separate books all rolled up into one. Really a very comprehensive look back at outbreaks over time. For clinicians and anybody interested in reading more scientific literature, this is the best resource that I have been able to find. It's called Lit COVID. This website is compiling all scientific publications related to COVID-19, and I've included the website up on top. Well, thank you again for everybody who joined us today. I really appreciate that. I'm happy to take your questions, and we'll try to get through as many of them as we can. And any of them that we don't get to, of course, I'll work diligently to respond to them separately and individually to you. Okay, so here's a question from Laura. How does COVID-19 cause ARDS? Okay, that's a really good question. The short answer is we don't know. We do know that SARS-CoV-2 infects epithelial cells in the distant airways and again binds to that ACE2 receptor in small airways. There's some data that, remember, there was elevated IL-6, T-cell dysregulation. Actually, there were even some autopsies from China that showed diffuse alveolar damage. So I think it's probably more of that. We know the viral titers decrease as the disease gets worse. So how much is related to direct damage from the virus versus, again, that immune response? That's going to be the ongoing debate that I think only time will answer. Okay, second question here. Jane, why is COVID-19 spreading so fast? Again, I think the answer to that has to do with viral shedding, in that there's very high levels of viral load early on in the disease, and we do know that it's shedding early on from the upper respiratory tract, as it was with SARS back in 2003. So the problem is that your initial clinical manifestations may be very small, you may not have any, and you might have a very high viral load, and you're walking around shedding this virus on surfaces and to other people. And I think that's likely what's causing this to spread so fast. And remember, that's in stark contrast to the original SARS back in 2003, where viral shedding and viral load didn't peak until much later in symptom onset. Even with Ebola, the same was true. We didn't have shedding and load increase until after symptoms really set in. So I think that's probably what's causing the rapid onset of this virus across the world. Brian here, how prepared are we in Beloit? Well, you never want to be too confident in times like these, but I can tell you, you can be rest assured that the Beloit Health System is doing everything possible to keep our community, staff, and patients safe. As mentioned, again, we've been talking about COVID-19 since January. We have a 24/7 incident command in place. Our team is comprised of, it's multidisciplinary. We've got infectious disease program, surgeons, physicians, nurses, emergency room staff, leadership. Again, our meetings are open to any that would wish to attend and contribute to our planning process. I feel our response has been very bold, very quick. I couldn't be more proud, honestly, be a part of this team and the response that we've currently put forth. Adam, what does SARS stand for, and why is the virus called SARS-CoV-2? Now that's actually a really good question because it's confusing. So let's go with SARS. Okay, SARS stands for Severe Acute Respiratory Syndrome. SARS-CoV-1 refers to the virus that caused SARS back in early 2000s, in 2003. SARS-CoV-2 is the virus that is causing the current outbreak. Because of its similarity to SARS-CoV-1, we went ahead and creatively named it SARS-CoV-2. The clinical syndrome is COVID-19. That stands for, if you break that word up, the CO in COVID stands for corona, the VI stands for virus, the D stands for disease, and the 19 refers to the year in which we identified the virus, which was 2019. Okay, Bob, I've heard a lot of R naught. What is it? I don't think you mentioned it. Okay, you're right. Actually, I didn't mention a concept called R naught. Okay, R naught is a basic reproduction number. It's a marker of how contagious a virus is. So we believe it's about, for SARS-CoV-2, we believe the R naught is about anywhere between 2.5 and 3.5. What that means, if you have one infected individual with SARS-CoV-2, that individual will infect 2.5 to 3.5 other people. So just putting that in perspective, historically measles is very contagious. Its R naught is about 15. MERS, influenza, their R naught is about 1. Sheila, can you discuss how common getting severe COVID-19 is compared to non-severe COVID-19? Absolutely. 70 to 80% of patients with COVID-19 have non-severe disease. 15 to 25% have severe disease, and 5% end up in the ICU. So fortunately, severe disease and ICU level disease is in the minority. But remember, I just piggyback on your question. Fever is present in most cases about 75% of the time at some point eventually, but only about 50% of the patients are febrile or have a fever upon admission. So just remember that the absence of a fever does not exclude COVID-19. Julie, does urine have COVID-19 in it? Great question. Direct answer is not that we're aware of. We do know that, again, a lot of viral shedding from the respiratory tract, sputum, nose, mouth. There's viral shedding in the stool, as we noted in the pediatric study. There can even be some shedding in the blood. That's been found in very severe patients. I am not recalling any evidence that suggests there's any shedding in the urine, though, so I would say no. Steve, why are bats the source of these infections? Okay, that's a very interesting question, okay, because you're right. Bats, they cause, we know for a fact, Ebola. We know they cause SARS, MERS. Many of the deadliest viruses have actually emerged from bats. I just want to say we don't know for sure that COVID-19 or SARS-CoV-2 came from a bat. It's certainly a strong hypothesis, but we're not 100% sure that it emanated from a bat and then crossed the animal-human barrier. My guess here, though, to your question of why are bats harboring viruses in general, is that it's likely related to the fact that they are, like us, long-lived mammals. They live in crowded areas. It's very easy for them to spread respiratory infections because they can fly, so they can carry those diseases long distances. In this context, remember, the bats are actually sold in markets and supplied directly to restaurants in China and Southeast Asia for consumption, and therefore, whether or not COVID-19 was transmitted from a bat directly to a human or a bat to another animal, often referred to as an intermediary host. You remember that SARS, the intermediary host, was a civet cat. MERS, we believed it was a camel. We don't really know, again, where SARS-CoV-2 came from. There was some initial discussion that it could have came from a bat and went to an intermediary host, being a pangolin, which is basically a scaly anteater, but that's, again, unclear and unproven. Interesting side note, there is an illegal pangolin trade demand because the scaly anteater, the scales that are on those mammals are used heavily in traditional Chinese medicine to ward off evil and other ailments. Okay, I see we got a lot of questions to get through. I think in the interest of time, let's just stop here. I'll work my way through the remainder of them, and I'll be in touch with each of you. Again, I really appreciate your attention, the strong attendance. I hope you found this useful. Please stay safe, and I look forward to seeing you really soon. Thank you.